Next, the midbrain, and this will be a little shorter than our lectures on the medulla and pons. Just as a big picture, of course, here now we're above the pons, and so we're going to look for cranial nerves 3 and 4. And here is the trochlear nucleus, which is really kind of at the base of the midbrain. We can see this is the only cranial nerve that exits the dorsum of the brainstem. It kind of has a very long course. That's why it's so susceptible to injury, like after a head trauma. Wraps all the way around here to supply the superior oblique muscle. And then we have the nuclei that contribute to the third nerve. In red here we have the oculomotor nucleus, which supplies all of the extraocular muscles that move the eye as far as the third nerve is concerned, and also supplies the levator palpebra to elevate the eyelid. In addition, we have here the Edinger-Westphal nucleus, and this is the parasympathetic contribution to the third nerve. And so we'll discuss the clinical applications of that. We also have the red nucleus here in the midbrain, and not shown because they're more laterally placed. This is a midline drawing. We will see the substantia nigra and the cerebral peduncle. All right, so looking here at this lower section here in the midbrain at the level of the inferior colliculus, let's first start with the pathways involved. So we've just called this the cerebral peduncle when we had our overview sort of gross brain structures. But now we can be more specific with regards to pathways here. The middle portion of the cerebral peduncle is made up of the corticospinal tract and the corticobulbar tract. So remember, the corticospinal tract is supplying anterior horn cells on the opposite side of the spinal cord to move your arms and legs. The corticobulbar tract supplies the lower motor neurons in the brainstem. Okay, and I'll show you a diagram of that in just a minute. Now, the corticopontocerebellar tract travels out in this position here in the cerebral peduncle. All right, so remember, what is the corticopontocerebellar tract? It does exactly what its name says. It goes from the cortex to the pons, okay, and it is headed down to supply these pontine nuclei. And so this is still a little bit of the pons that we're seeing. Even, when you make a section like this, you get a little bit of the midbrain, a little bit of the pons. So the corticopontocerebellar tract is synapsing with these pontine nuclei, which, remember, will then cross over through the middle cerebellar peduncle, which we don't see at this level. All right, in terms of other pathways, we have here the superior cerebellar peduncle. Now, this is actually the decussation of the superior cerebellar peduncle. So our next lecture is on the cerebellum, and I will tell you that one side of the cerebellum talks to the opposite motor cortex and vice versa. Okay, and so these pathways cross right here in the midline. This is a very large pathway. When we did our gross brain dissections, you can frequently see this with the naked eye just when you're cutting through the lower midbrain. All right, so remember, this is output from the cerebellum to the motor cortex. We still find the medial longitudinal fasciculus here in this midline position. So remember, internuclear ophthalmoplegia and its relationship to multiple sclerosis. All right, our sensory pathways have now moved out laterally here. So the medial lemniscus and the spinothalamic tract. So this is why this rule of fours and things like that for the brainstem are not always accurate, because the medial lemniscus is now lateral when we get into the upper pons and midbrain. And remember, these two pathways are headed to the VPL of the thalamus and then to the post-central gyrus for all sensation for the arms and legs. Pain and temperature as far as the spinothalamic tract, vibration proprioception for the medial lemniscus. Okay, the lateral lemniscus, remember, is auditory information as it ascends through the brainstem, and this will synapse here in the inferior colliculus. So the inferior colliculus is an auditory relay nucleus, and sound from here will head up to the medial geniculate body of the thalamus. Remember, that's the thalamic nucleus for sound. Okay, so in our next level, we won't see the lateral lemniscus anymore because it's all synapsed here in the inferior colliculus. Remember that the tectospinal tract originates from the superior and inferior colliculus. So there's a descending pathway here. So sound comes up to the inferior colliculus, and then again, this tectospinal tract descends down to the cervical anterior horn cells, so you can turn your head with respect to sound. And when we get up to the superior colliculus, you can turn your head accurately with response to vision. All right, we see the cerebral aqueduct again here, surrounded by the periaqueductal gray, which is very large. And remember, I told you these are loaded with opioid receptors, very important in terms of our response to pain. We can see the trochlear nucleus right here. So this is a very a dorsal nucleus here, and we'll see on the next slide how the nerve actually wraps around like this, kind of crosses over. It's the only cranial nerve that crosses. All of the others supply ipsilateral structures. Okay, we can still see a lot of the reticular activating system here, kind of this puff of smoke that's all around here. Okay, we've talked about the function of that. I mentioned the pontine nuclei and its relationship to the corticopontocerebellar tract. And then finally, we have a very important area here called the substantia nigra. And this will get larger in our next section. So very important clinically that you remember that dopamine is produced here and projects up to the other basal ganglia structures. Okay, so we'll see this again next time. And remember, degeneration of the substantia nigra results in Parkinson's disease. Okay, so just a reminder on the corticobulbar tract. So this travels right along with the corticospinal tract, so originates in the precentral gyrus, travels through the genu of the internal capsule, and so it's supplying the lower motor neurons in the pons and in the medulla. So the trigeminal motor nucleus for chewing and so on, the facial nucleus, nucleus ambiguus, remember motor for 9 and 10, swallowing, talking, hypoglossal nucleus, spinal accessory nucleus. So it's really just the corticospinal tract, all right, but it's specialized for the brainstem. And remember, the supply of the corticobulbar tract is ipsilateral and contralateral, with the exception that the part of the facial nucleus for the lower face does not get an ipsilateral supply. And remember, that's how we explain an upper versus a lower motor neuron facial weakness. And boards love to ask about a lesion in the genu of the internal capsule resulting in contralateral lower facial weakness, and so that you don't diagnose that as a Bell's palsy, but rather the patient had a stroke or demyelination or something else going on there in the genu. Okay, so remember, the corticobulbar tract occupies this location in the cerebral peduncle right next to the corticospinal tract. Now, just to review auditory pathways, we have a whole lecture on this, but since we've been going through this in the brainstem, so we have sound coming in here to the cochlear nuclei, and I've told you don't need to know the different cochlear nuclei. Okay, and then as it goes up, it crosses back and forth many times. Then there's a superior olivary nucleus. There's actually a medial and a lateral superior olivary nucleus, but that's not important. We have crossing back and forth, and then this travels up through the lateral lemniscus. There's the nucleus of the lateral lemniscus as well, and then the inferior colliculus, then the medial geniculate, this thalamic nucleus that processes sound, and then Heschel's gyrus, which is the primary auditory cortex. Right, so a medical student just drew this recently, which I thought was really helpful. And also, I want you just to appreciate how much back and forth crossing there is of auditory information. And when we get to the stroke lecture, I'll make a bigger deal of this, but we basically never see hearing loss in a brainstem stroke because you'd have to have lesions on both sides. Okay, so hearing tends to be preserved with lesions in the brainstem because of the back and forth crossing. Okay, there always has to be an exception, so I will tell you about that in our stroke lecture, but as a rule, hearing is preserved with lesions of the central nervous system. All right, now just a reminder, we've already talked quite a bit about the trochlear nucleus here, this very long course coming around, crossing to supply the superior oblique. We've spent quite a bit of time talking about the action of the superior oblique, and that patients that have a lesion of the superior oblique, that eye is just a little bit higher. And since the primary function of the superior oblique is down and in, when the eye is looking towards the nose, it's very strong as a depressor action. That we can see here, this patient with the left superior oblique palsy, it's just a little hyperopia of the left eye. It's a little bit higher. Okay, it's subtle, but it's just a little bit higher. And so what's most helpful when you're suspecting a superior oblique or a fourth nerve lesion is have the patient tilt their head back and forth, because when you tilt your head towards the side of the lesion, that's when this eye, to fixate on the target, encyclotorts. It wants to turn down and towards the nose. And since that can't happen, we have a very prominent disconjugate gaze. And so patients that have a fourth nerve palsy, usually not this obvious, but they tilt their head to the opposite side. And you can just look at photos and kind of go back and see how long they've been tilting their head. And if you don't know the onset of the fourth nerve palsy, looking through photos can be a helpful way to determine when it started. All right, here's a cartoon version of what we just went through so you can practice going over all of those structures. Okay, and our last midbrain, well, only two sections here in this lecture, is a familiar one because I showed you a cartoon drawing of this in our introductory lectures. And so here we're at the level of the Superiorcolliculus. So all the auditory information now, we don't see a lateral lemniscus or an inferior colliculus. Instead, what we see here is it synapses in the medial geniculate here of the thalamus. So remember, this is the thalamic nucleus for sound. Okay, in terms of pathways, we still have here in the cerebral peduncle the corticospinal and corticobulbar tract in the central location, the corticopontocerebellar tract here on either side in the cerebral peduncle. All right. Otherwise, in terms of pathways, we still have the medial lemniscus, again in a lateral position in the midbrain along with the spinothalamic tract. And I decided not to go higher than this, but if we were to go up just one more section, we'd see the lateral geniculate and the synapse of these pathways in the lateral geniculate nucleus. All right, so let's start from the back here. We have the pineal gland, and notice its close relationship here to the cerebral aqueduct. So if we have a tumor of the pineal gland, that can easily compress on the dorsum of the midbrain, can compress the cerebral aqueduct, and then the patient will get a non-communicating hydrocephalus. And we'll finish this lecture talking about what else we can see if we have a compressive lesion on the dorsum of the midbrain. All right, so we have the Superiorcolliculus. So remember, this relates to vision. The tectospinal tract we just talked about, descending from the Superiorcolliculus. There are other visual functions of the Superiorcolliculus that I won't go through, but this is not visual acuity. This is more, has to do with eye movements. Now, here is the third nerve. And notice the third nerve we can see here, and it kind of got cut off over here, but we can see the fascicles of the third nerve over here, that the third nerve comes out in between the cerebral peduncles. This is called the interpeduncular fossa, the space between the peduncles. So if we just follow the third nerve back, we can see the nuclei that contribute to the third nerve. So medially, we have the Edinger-Westphal nucleus, and laterally, the oculomotor nucleus, or the third nerve nucleus. And so again, Edinger-Westphal is the parasympathetic contribution to the third nerve, all right, and that is to constrict your pupil, whereas the third nerve nucleus again supplies the extraocular muscles and also the orbicularis, the levator palpebra. Only other thing to point out here is the red nucleus right in this location. This is a little bit, I didn't label it here, but the superior cerebellar peduncle is still in this area, so there's a lot of white matter as well, so I just kind of drew this to help you out here that this is the location of the red nucleus. So what do you know about the red nucleus so far? Well, in our spinal cord lecture, we said that the rubrospinal tract is an upper motor neuron pathway that originates from the red nucleus, has a similar function as the cortical spinal tract, although much less important in humans. And also, when I talked about the central tegmental tract, remember that connects the inferior olivary nucleus with the red nucleus. So here is the central tegmental tract, and I put some arrows here to kind of show the synapse here with the red nucleus. And so remember, if we have a lesion of the central tegmental tract that disconnects the red nucleus from the inferior olivary nucleus, the patient will have palatal myoclonus. And the red nucleus, as we'll see, is also very important in terms of cerebellar circuitry. All right, so let's make some clinical applications of this. First of all, we have a syndrome here called Weber's syndrome. And this is due to an occlusion of a branch off of the posterior cerebral artery. So let's follow the basilar artery up into its termination, and then we can see the posterior cerebral artery. It's kind of wrapping around the third nerve there. The superior cerebellar artery is just below it. And so notice the midbrain is deep in here. If you were to put your finger in here, you'd see the midbrain. So the posterior cerebral artery is just kind of lying on the midbrain. And so these little penetrating branches, okay, here's the basilar artery, here's the posterior cerebral artery. So we get these little penetrating branches off of the posterior cerebral artery that supply most of the midbrain. The dorsum is supplied by the superior cerebellar artery, but I don't really care that you know that. So for our clinical applications, we're going to talk about the branches off the posterior cerebral artery. So if we have an occlusion of these little branches here, then we tend to get an infarct here in this portion of the midbrain. Okay, and so that is going to involve the cerebral peduncle, which we see right here. So that'll give a patient a contralateral hemiplegia. And remember, the third nerve is coming out right here, so we will get an ipsilateral third nerve palsy. Okay, so here's where the stroke is in Weber's syndrome. Ipsilateral third nerve, contralateral hemiplegia. And remember, that's what we've seen with every single brainstem syndrome that we've talked about. It's always ipsilateral cranial nerve involvement, contralateral, in this case, motor involvement. So here's a nice drawing showing you a branch occlusion off of a PCA. So we're going to get an ipsilateral third nerve palsy. So in this case, a left third nerve palsy. And here's the cortical spinal tract, hasn't crossed yet. So we get a contralateral hemiplegia. So the patient can't open their eye. If we were to lift up the eyelid, we'd see the eye in the down and out position. And they have a contralateral hemiplegia. So it's important not just as kind of a theoretical academic exercise, but why do we care to be able to localize these brainstem syndromes so well? Well, when someone comes into the emergency room, they have a hemiplegia, and okay, this patient has had a stroke. When we get to neuroradiology, this will make more sense. But CT scans do not visualize the brainstem very well. So if we know that we've localized the lesion to the brainstem, maybe it's lateral medullary syndrome or Weber's syndrome, then we really want to get an MRI soon to visualize the area. So in other examples I can give, it makes a difference what you're going to do for that patient in the acute setting. All right, so here's a 12-year-old who came in with acute double vision and right-sided weakness. And so what we notice here is that we have ptosis of the left eye, and this pupil looks a little bit larger, and it looks like it may be down or out just a little bit. things in neurology are rarely 100%. So you might imagine, boy, every third nerve palsy, the eyelid's going to be closed and the eye will be way out here. But things are often partial. And so this is a kind of a partial third nerve palsy. We can see that when the boy tries to look up, he really can't look down either. I wish I had a picture here showing you, if he was to try to look to the right, since the medial rectus is supplied by the third nerve, this eye would not be able to look medially, but since the sixth nerve supplies the lateral rectus, he would do well looking at an object off to his left side. Right, and when we shine a light in the right eye, we get brisk pupillary constriction, nothing over here. So again, the parasympathetic fibers are involved. If we were to shine the light in this eye, we'd see the same thing over here. We'd get good pupillary constriction here, but not much going on in this eye. Now, another condition that can involve just the pupil is called Adie's tonic pupil. And first, let's just review a little bit of the normal anatomy here of pupillary constriction. Remember, when light comes into one eye, that some will stay on the same side here through the optic tract, some will cross over to the opposite side, and so we get bilateral stimulation of the pretectal nuclei back here, which I decided not to label in the midbrain diagram. It's not a very large nucleus. And then we get kind of a double crossing here as well at the posterior commissure. So light in one eye is going to end up eventually equally stimulating both Ehninger-Westphal nuclei, which we see here and labeled over here. And so then the output is via both third nerves. In this case, we're just showing the parasympathetic fibers. Okay, and these go through the ciliary ganglion and then via short ciliary nerves to constrict the pupil. All right, so that's the normal parasympathetic supply of the pupil. Now, Adie's tonic pupil is something where, for usually unknown reason, we have degeneration that comes on abruptly of the ciliary ganglion. And so, for whatever reason, this tends to occur somewhat more likely in young, healthy women, and it seems like almost every patient that I've seen with this, they're looking in the mirror and they notice that one pupil is dilated. And that's concerning, obviously. If you watch enough doctor emergency room shows, pupil dilation, that sounds really bad. And so these patients often come to the emergency room and they're normal otherwise. They just have one big dilated pupil. Does not affect the part of the third nerve that has anything to do with your eyelid or moving your eye. So everything is normal except they have this big dilated pupil. All right, so we can always suspect the diagnosis, but how can we confirm it? And so, again, a nice drawing a medical student did here just a few months ago. So this is the normal eye, and so I should have had another drawing here showing you just an ambient light, but just imagine this is the normal size of the normal right pupil. Okay, now when we shine the light in both eyes, okay, maybe just have bright room lights on, or we use flashlight or otoscope and we shine the light in both eyes. Notice that this normal pupil constricts a little bit, just like you'd expect. Okay, but this pupil is just stuck in this big, position here. We have severe mydriasis. So light does nothing to the Adie's tonic pupil. Okay, now what happens over time is as the nerve tries to regrow and rewire, we get this aberrant reinnervation. I think it has a typo in your handout. It says regeneration. It's reinnervation, aberrant reinnervation. And so that ends up with the nerves being kind of misguided. And so we tend to get, over time, a brisk pupillary constriction to accommodation, looking to the nose, because that is a different, different pathway, different wiring. And so accommodation is preserved, but the pupil does not constrict very well to light. Okay, so that would be quite suggestive of Adie's tonic pupil, but there's something else we can do. We can give a very dilute solution here of pilocarpine. Pilocarpine is a cholinergic agonist, and So cholinergic sounds like acetylcholine, right? So it's a acetylcholine agonist, but it's very dilute. It's so dilute that it does nothing to a normal pupil. Okay, because remember, the parasympathetics use acetylcholine on muscarinic receptors. And so if we were to give a strong concentration of pilocarpine, well, then we'd really stimulate this pupil and it would constrict. But if it's really dilute, it does nothing to the normal pupil. But notice what happens here in an Adie's tonic pupil. We go from this to this. And the reason is over time, because this pupil, it wants to get acetylcholine, it wants to constrict. And so you get an upregulation of muscarinic receptors, lots and lots of muscarinic receptors looking for acetylcholine. So then when you give just a little bit of pilocarpine, you get a super constricted state of the involved pupil. Okay, so this is how we can be here definitive in our diagnosis of an Adie's tonic pupil. And these patients do well. It's often just kind of annoying. There's more light sensitivity if your pupil is dilated all the time. Okay, a cartoon drawing of everything we went through. And then the last thing I want to tell you about is the dorsal midbrain syndrome. So remember, this is the dorsum of the midbrain. And this is otherwise known as Parinaud's syndrome. Okay, we made a big deal about the pons being important for horizontal eye movements. All right, the midbrain is responsible for vertical eye movements. Remember locked-in syndrome, where the patient has preserved up and down eye movements. So if we have a mass lesion here, and again, here's the pineal gland, so if we've got a pinealoma, we can get this dorsal midbrain syndrome. And so the patient is going to have a vertical gaze paralysis. And every year I've given this lecture, I get emails from students wanting to know, well, how does it work for vertical eye movements? And so I'm going to anticipate that question, but also just tell you, you don't need to know this. All right, but for those of you, just so that it's not a magical thing, and maybe you'll see why I have never gone into vertical eye movements, because they're so complicated. So just relax for 2 minutes, and for those of you that are curious, I'll show a little bit how it works. So just imagine like the vestibular ocular reflex. When you move your head up and down, your eyes are going to correspond and go up and down. And so that occurs again through the vestibular apparatus here. Okay, which to move your eyes vertically, this has to go in here to the fourth nerve nucleus, which is going to supply the superior oblique. Okay, but we also need to get the third nerve nuclei to, work in conjunction. And so this pathway goes up to some areas. Again, you don't need to know the interstitial nucleus of Cajal, the rostral medial longitudinal fasciculus. These are the two main areas involved in coordinating vertical eye movements, and then they communicate with the appropriate third nerve nuclei. This is all the third nerve oculomotor nucleus, right and left. Talk with the appropriate oculomotor nuclei to move your eyes in a vertical direction. Okay, so do you need to know that? Absolutely not, but you do need to know, and I've seen this quite often on a National Board subject exam, that this area of the brain is important for vertical eye movements, and now you have a little better sense of why that is. Okay, so in Parinaud syndrome, they have a problem with vertical gaze. The other thing that's affected is, again, the pupils. And I hope this doesn't confuse you, because the midbrain orientation is opposite of the last drawing. But so remember, light comes in here, goes to the pretectal area, crosses over. This doesn't show what happens here on the other side, but remember, some light crosses over here as well to stimulate the Edinger-Westphal nucleus, and so that your pupil constricts, and this happens on both sides. Well, if you have a mass lesion, again, let's stick with our pinealoma example, you impair the ability of the pupils to constrict to light, because you have, a destructive lesion in the pretectal area. So the pupils tend to be a little bit large, sometimes a little bit irregular, but pupillary constriction is spared to accommodation. So again, that's looking to the nose. And that's because accommodation, if I were to have you look at my finger and follow it to your nose, this involves tracking, so it comes from the visual cortex, And it activates this via a different mechanism, a different pathway. So accommodation tends to be preserved. So again, if you've got a lesion of the dorsal midbrain, we tend to get this where the pupils don't constrict to light, they do constrict to accommodation. And when we talk about HIV later, I will tell you that neurosyphilis is classically a condition. This will be the classic board question back here, where the pupils don't constrict to light, but they do constrict to accommodation. But that's not specific for any condition. It just tells you where the lesion is. The other thing we can see with a lesion of the dorsal midbrain is that the eyelids tend to pull up like this. The patient always looks surprised. Okay, so here's a child with the pinealoma. The eyelids kind of retracted a little bit. And then when the patient tries to look up, they can't. And so the eyes come briskly together towards the nose, and they kind of shake back and forth. This is known as a convergence retraction nystagmus. And I'll show you a video of what this looks like in class. And then I just wanted to remind you that the cerebral aqueduct is right there in the dorsal midbrain. So if we have a big pinealoma, then the patient can also have a non-communicating hydrocephalus, and obviously that could be very dangerous. All right, so just how do you look at the brainstem? It's one of the more difficult areas of neuroscience, and so just as a big picture, know where the cranial nerves are located. So 9 through 12, medulla, 5 through 8, pons, more or less, and cranial nerves 3 and 4 in the midbrain. Remember that they don't cross except for the fourth nerve, and that is not clinically significant. I will have no questions asking you just with an arrow pointing to something with a question, identify this nucleus. It will all be a lesion here could produce which of the following. So for me, this is only relevant if you know the clinical significance of this. Make sure you're always aware of where the pathways are. The cortical spinal tract should always be able to identify where that is. The medial lemniscus should always be able to identify where that is. The spinothalamic tract in the medulla, it's so small, that I didn't ask you to identify it, but you need to know where it is. You need to know that's part of lateral medullary syndrome, and that this is part of the whole lateral brainstem eventually joining together with the medial lemniscus. And then just make sure that all of these clinical syndromes that we've talked about, that you really know those very well.